Graham.
Thank you very much. Well, thank you very much indeed. It's a pleasure for me to join the Garfield group at this important symposium. I'd like to thank the organisers for allowing me to present the data on heart failure. Here are my disclosures. As we've heard, atrial fibrillation and heart failure often coexist and is associated with a worse prognosis than either treatment alone. Also, we've heard from Dr. Goldhaber about the role of biomarkers predicting stroke in patients with atrial fibrillation. You can see that some of these biomarkers are common to atrial fibrillation and to heart failure. And finally, as also pointed out by Dr. Goldhaber, heart failure is a leading cause of death and readmissions in patients who have atrial fibrillation. Because of the very rich database in Garfield, we were able to look at the contemporary management of patients who have the combination of atrial fibrillation and heart failure. In addition, we can look at the characteristics of these patients and the current use of both anticoagulant and antithrombotic drugs, as well as the specific management of heart failure. So the objectives of our analysis in Garfield is to look at the characteristics of the patients with newly diagnosed atrial fibrillation who present with comorbid heart failure, to assess the patterns of the antithrombotic and heart failure treatments, describe the increased risk of heart failure for all-cause mortality, stroke and systemic embolism, and major bleeding. And we looked at this in the first year after the diagnosis of atrial fibrillation. Of the 52,000 patients who were entered into the Garfield registry, cohorts 1 to 5, we had New York Heart Association classification of heart failure available in 51,180 patients. And as you can see here, 18% of the patients who are admitted with atrial fibrillation also had comorbid heart failure, and you can see the breakdown into the various New York Heart Association classes. Looking at the clinical characteristics of the patients with no heart failure, and we divided them into those who have class 1 to 2 and class 3 to 4, you can see that, not surprisingly, some of the risk factors for further adverse events are much more common in the patients with a class 3 to 4. They're older, much more diabetes mellitus, there's more in the way of vascular disease, and there is certainly more chronic kidney disease. And this is not a surprise. These are much sicker patients and tend to have many more comorbidities. Once again, looking at the clinical characteristics, not surprisingly, the patients who have heart failure have more coronary artery disease. Not much difference in the types of atrial fibrillation, except that the patients who have New York Heart Association class 3 and 4 have the highest frequency of permanent atrial fibrillation in comparison to those with no heart failure or class 1 or 2. Looking at the antithrombotic treatment patterns, this is an interesting observation. You can see that those with no heart failure have 66.7% anticoagulant therapy, whereas the patients who have New York Heart Association classification 4, there is much more in the way of antiplatelet therapy administered, and only 56.5% are receiving anticoagulants. So the more severe the heart failure, the clinicians contemporarily tend to give the patients more in the way of antiplatelet drugs in comparison to anticoagulants. Looking at specific heart failure therapy, the current standards and recommended treatments, ACE inhibitors, aldosterone blocking, or other diuretics, beta blockers, you can see that there is a tendency for greater use of these treatments in the patients as the heart failure degree increases. But very surprisingly, you can see that there's still quite significant use of digitalis or digoxin preparations in heart failure, despite all of the recommendations that this is of very little value. Looking at the care settings, now do remember that this is where the patients were first presented with the atrial fibrillation. You can see that in cardiology, there's much more use of aldosterone blockade than in internal medicine or in primary care. But for beta blockers and for ACE inhibitors, you can see that both internal medicine and cardiology, as well as primary care, are fairly similar in terms of the use of these medications. Looking at the outcomes, and again this is presented as per 100 patient years, not surprisingly again you can see that the worse the heart failure, the worse the outcome for the patient, with increasing rates of stroke and systemic embolism, increasing rates of major bleeding, and increasing rates of all-cause mortality. And about a quarter of the patients who have heart failure class 4 are dead within the first year. Once again, continuing at looking at outcomes, once again, event rates per 100 person years, cardiovascular death, non-cardiovascular death, you can see increases with the degree of heart failure. New acute coronary syndromes, once again, increasing with degrees of heart failure. And of course, worsening or new heart failure is quite clearly more prominent in the patients with more severe presentation of the disease. So to conclude, in contemporary management of patients with atrial fibrillation, worldwide in a global registry of 51,000 patients, 18% of them have heart failure as at diagnosis of atrial fibrillation. They are older and sicker when they have greater degrees of heart failure in comparison to those without. Anticoagulant therapy was similar between groups except those in New York Heart Association Class 4, where clinicians are more likely to administer antiplatelet therapy. There's been better implementation of heart failure treatments in the patients with more severe disease, particularly aldosterone blockade. Surprisingly, there is still quite a high rate of administration of digitalis and other digitalis analogues. Gradual increase in event rates as the New York Heart Association class increases, and therefore I think it's important, as pointed out already, that we take a holistic approach to the management of patients with atrial fibrillation and take into account the management of the comorbid conditions. Thank you very much.